Thank you very much. I have a lot to tell, and when I listen to the previous two speakers, I think there are a lot of questions and still going on, and a lot of things we all have been experiencing, especially on the morale of the workers at home and the workers in the hospital. So I would like to give an overview of our experience so far and the questions we still have. We are an academic hospital in the east of the Netherlands. We upgraded our ICU capacity from 28 beds before COVID until a double number of beds up till now, with still available non-COVID care beds for patients needing other urgent care. We were actually close to the center of the pandemic in the Netherlands, which was in the east and in the south. So we started to get patients early in March 2020. And due to the social distancing things we had to do and other things applied by the government, we now see that our hospital admissions are decreasing from the end of March. So that's good news. So you all explained how your hospitals went through different phases, and we did that as well. We are an academic hospital, so we have a lot of research staff, but we also have 50 staff physicians, including nuclear medicine and radiology. And we have 4 CT scanners, and one of those CT scanners is on the emergency ward as well. And our phases included a preparation phase, an acute phase, and a chronic phase. And in the preparation phase, we were developing risk scenarios and schedules for staff, like you all did. And we already started to move clinical workstations to home offices for home reporting early in March. We scanned our first COVID-19 patient on March 14th, so that was later than in Strasbourg. And at that moment, 50% of our staff worked from home, and our residents were scheduled on all-night and weekend shifts, and research needed to be suspended, and this was a hospital-wide decision. And we started to do patient care, which I will explain on the next slide. Now we are in the chronic phase, as you explained previously, and we are restarting work at the hospital, but still a lot of people are working from home. So what did we do with our patient management? We developed reporting schemes in a previous phase, and we explored the role of CT. And as you all know, the 3 hospitals who are included in this webinar all performed CT as a primary, which had a primary role in COVID-19 management, but this was not advocated by, for instance, the American College of Radiology, or you couldn't base this decision based on reports from China, which were pretty enthusiastic about the role of CT in COVID-19 disease, but also had some moderate quality. So it was very hard to decide what the role of CT would be in that phase. So we started to explore this, and we made a separate workflow for suspected COVID at the emergency room as well. And we could do this because we had the logistics for that. We had the emergency room CT scanner, and we were able to make separate workflows. And during our acute phase, we didn't stop elective care. We actually did a lot of urgent elective care still. We kept on scanning cardiac patients in order to avoid collateral damage. And as long as we were able to do that, we kept on doing that. And once we would go into another code, red or black, we would also stop that. But we were very lucky that was not the case. We performed low-dose CT in patients with all patients with airway symptoms who entered the hospitals, who needed hospitalization, and who were suspected for COVID-19 disease. So in patients with a high likelihood of COVID-19. We did not scan patients in asymptomatic phases, pre-symptomatic phases, or in patients needing surgery. And now we're going into the chronic phase, and we're going to restart regular care for non-urgent patients as well. So how did we do our logistics? we had the basic assumption that COVID transmission is done via droplets, and well, there has been a lot of discussion about aerosol transmission, but we considered it not very important. So in close collaboration with our hygiene departments, we decided to do cleansing of any contact surfaces, and that would be sufficient for hygiene, and of course good preparation of your staff and good protection of your staff and separate routing. So we had one technician in PPE who is in the contaminated area of the scanner for 3 hours. After that, you have to change your clothes because you're not protected anymore. And this technician is waiting in the CT preparation room, preparates the patient, and then goes back into the preparation room, and the patient is scanned. And we perform a low-dose CT scan in all patients with a DLP of about 40 milligray centimeters, which is way below 1 millisieverts for most of the patients. And the technician outside at the console is scanning, of course, and then the patient goes out, gloves are changed, and the room is cleaned. And with that, we could also do 4 patients per hour. And at the top, we did 40 scans per day, but it was not very, we did it not very frequently. Just like in Strasbourg, we had a uniform way of reporting CT scans, and in the early phase we had been thinking not only in our hospital but also nationally to do that in a very uniform way in order to be very clear to our clinicians also on likelihood of disease. So we actually designed more groups of likelihood of disease, 5 groups. In patients who were had a proven COVID-19 disease with a RT-PCR positive result, we called it a Co-rads SES, and this Co-rads terminology is in line with the RADS, other RADS terms from BI-RADS, long-RADS, etc. With Co-rads 1, a very low likelihood of disease, and Co-rads 6, a very, very high likelihood of disease. And this is an example of a Co-rads 5 patients, and in Co-rads 5 patients you need to have the very typical signs of COVID-19 disease with pulmonary involvement, which means bilateral ground glass, with or without consolidations, multifocal, in the periphery or close to the fissures, with some kind of confirmatory pattern, such as crazy paving, organizing pneumonia, or something which resembles organizing pneumonia, subpleural banding, all typical findings. And if you see that, you can say this is a Co-rads 5, and in our center, 98% of patients with such a pattern actually turned out to have COVID-19. So we had a very high specificity. The term Co-rads 4 is also kept for patients with typical findings, such as peripheral ground glass, but not in a typical distribution, such as in this patient who only has ground glass in a unilateral way, but also if ground glass is, for instance, superimposed on previous other pathology. And if in our center, about 80% of patients with this type of, with a Co-rads 4, had turned out to have COVID-19. Co-rads 3 is the I don't know group, and of course we have to keep this group as small as possible. So it was like 10 to 15% in our clinical practice. And in this group, you actually can't get any information on likelihood of disease here. But it's very important to be clear on that as well to your clinicians. And finally, we have Co-rads 1 and Co-rads 2 categories, which means that Co-rads 2 is an infectious an image of infectious disease, such as an infectious bronchiolitis or a bronchopneumonia, which is clearly not COVID-19, so without any typical feature of COVID-19. And finally, we have Co-rads 1, which is either a normal chest CT or an abnormal chest CT, but without any sign of infectious pathology. And in this way of calling this the likelihood to our clinicians were very rapidly in adapting this likelihoods, and they were actually using it in making decisions. We were a little bit like, okay, that's really fast, but it actually seems to work, and the areas under the curve are pretty high. The observer variability turns out to be high, with an area under the curve in one of our observer studies of 0.91. But of course, you have to bear in mind that that pneumonia is not the only expression of COVID-19 disease. Such as in this patient, this is a 63-year-old man who came in with hematemesis and upper gastrointestinal bleeding. And we performed a CT of chest and abdomen. And as you can see, there is a Co-rads 1 lung without any infectious pathology there. But he actually had thickening of the distal esophagus and mucosal enhancement. And this person turned out to have a positive PCR, did not develop any pulmonary symptoms across his hospitalization, but he turned out to have an COVID-19 infection of his distal esophagus, which is actually really rare. So you have to keep in mind that Co-rads only resembles pulmonary pathology in COVID-19 disease and not other expressions of the disease. We also have a kind of, in a report, we also have a kind of measurement of extent of the disease in order to estimate, well, whether there is a kind of measure to predict deterioration of patients or to have a kind of assessment of severity of the disease. We don't actually know whether this will be very predictive, and we have to combine that with other clinical parameters, of course, and this has been published in many papers already. So our CTSS is a little bit different than what you use in Strasbourg, but I think it's the same intention. So what did we learn? And I think you previously meant it as well, that solidarity and collaboration were really were really high. But not only in the departments, also hospital-wide, between departments, but also in the country. So this Co-rad system was actually developed with a lot of Dutch radiologists who all collaborated, which made it possible to enroll this across the country very fast and prove it very fast. The other downside is the social problems you have when you work at home and the distancing problems we now face at the hospital. How are we going to manage that? And then from the organizational perspective, it really helped to be prepared and to make estimates of different scenarios for the future. And this helped us to change our management fast and frequently, and it helped to use uniform reporting. And yeah, what we also learned is that we still kept urgent regular care alive as much as possible in order to reduce collateral damage.